Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Yogendra Kumar, hepatologist at Livasa Hospital, Mohali, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hello everyone, my name is Dr. Yogendra Kumar and I am working as a senior consultant in the Department of Gastroenterology and Hepatology at Livasa Hospital, Mohali. I did my MD and DM from PGIMR Chandigarh and currently practicing at Livasa Hospital, Mohali.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
So, IBS is a gut-brain synchrony basically, and in simple word we can describe it as a diagnosis of exclusion. Means if you have to rule out other causes which can cause bloating, gas, dyspepsia, diarrhea, white stool. So if all the other causes are ruled out and if there is no significant cause is there or any pathological cause is there, we can say that this patient is having IBS.
Why do you think IBS remains one of the most underdiagnosed gut conditions in India?
That the symptoms of IBS are abdominal pain, then your gas, bloating, constipation and diarrhea, and various conditions such as if you have an infection of your gut, if there is lactose intolerance, if there is gluten sensitivity, or if there is any kind of then these symptoms are very much similar with IBS. So people generally thought of other infective causes and other things instead of IBS in various scenarios. So mostly it is underdiagnosed condition. It also is similar with IBD, means inflammatory bowel disease. So we have to first rule out all the conditions, and if there is no pathological cause is there, we can say that this is a IBS.
In your experience, how does a typical IBS patient present in an OPD?
The typical symptoms, patient come and say that डॉक्टर साहब खाने के बाद मुझे स्टूल जाना पड़ता है, खाने के बाद मेरे पेट में इतना डिस्कम्फर्ट हो जाता है कि बिना स्टूल पास किए मुझे चैन नहीं आता. Then they also complain about pain abdomen, bloating. Sometimes they complain of having constipation, and after sometimes they can complain of diarrhea. So IBS can be your having IBS D means diarrhea. In that patient will have a very loose stool, and in another condition in IBS C means IBS constipation, in which patient presented with severe constipation and hard or lumpy stools. In another condition IBS is mixed type, where both constipation and loose stool are there in the same patient. And the fourth one is unspecified, that is called IBS U. So these are the basically four types the patient presented in a OPD.
What are the biggest myths or misconceptions you hear from patients about IBS?
The biggest myth is that patient thinks that curtailing his means one patient hear something about that this patient is having IBS and the patient stopped these kind of food and then IBS improved. So this is the biggest myth is that one food is trigger for other person and not for himself. So people think that अगर ये नहीं खाना खाऊंगा तो IBS ठीक हो जाएगा. Then they curtail the milk products. Basically, patient having lactose intolerance or gluten sensitivity also presented symptoms like IBS, but the condition is not like that. Means patient is having IBS but there is no lactose intolerance. But the people think that if they curtail their dairy products, then the IBS condition will improve. Another one is that the symptoms of IBD and IBS both are similar kind of. So patient think that I have means IBD also. So and the third biggest myth is that if you stop eating or eating a very less amount of food, then your IBS will be cured. So these are the various myths which patient presented in OPD.
Is IBS really a stress disease, or is there more to the story?
So basically, IBS is, although a stress is contributing factor in IBS, no doubt about this, because a patient who is having anxiety, depression or post-stress traumatic disorder, it can trigger IBS, but it is not the cause. The patient can have gut infection, patient can have lactose intolerance, patient can have subacute intestinal bacterial overgrowth. So these are the various other conditions also in which patient can have symptoms like IBS. But the people think that stress is the only cause. It's not true. Stress is one of the cause, important cause, but not IBS is not only the stress disease.
How does modern lifestyle food habits, stress and sleep contribute to IBS?
So as we know that there are long shifts in nights, means there day and night shifts are there. People working in IT professional or in any multinational company, in that people work day and night and the sleep pattern disturbs. So the very important factor to release your stress is a good sleep hygiene. So people are missing that in this modern era. Then the eating habits, the patient who has fast food basically, like your fructose corn syrup or burger or anything with fast food, that will produce more gas, bloating or pain abdomen. So there is fact that in modern era, these are the stressors which aggravate symptoms of IBS.
What are the top 3 red flags that make you suspect IBS in a patient?
So the top 3 red flags, basically there are various red flags when you have to go to your gastroenterologist. First is if you have unexplained weight loss, if you have unexplained iron deficiency anemia. That IBS is a disease which is very basically teenager disease and mostly present before 40 years of age. And if the first appearance of symptoms is above 40 years, this is a red flag. And if there is a fever, bleeding per rectum, so these are the red flags when you have to consult a gastroenterologist. And patient of IBS generally present with diarrhea, then constipation and pain abdomen, and they can have whitish mucus discharge during their defecation. So these are the signs when you have to consult a gastroenterologist.
What simple screening questions can a consulting physician ask to suspect IBS?
So the most important thing in diagnosing IBS is your history taking. Your history taking should be very, very good, because there is no specific test which can suggest that this person is having IBS. So first, history is very important. You have to find out the stressor part in the patient. Then you have to exclude the pathological conditions such as IBD, SIBO and gut infections. So the most important part is history taking. So you have to take a proper history and ask the patient about the stool diary and the activity diary. So the important thing is history. Good history can lead to diagnosis of IBS, and you have to do other tests to rule out the other conditions such as IBD, colon cancer, the ulcerative colitis or Crohn's disease, or if there is any growth in the gut. So colonoscopy, then blood test and then stool examination. So these are the few tests which can be advised in a patient who is presenting to your OPD with a diagnosis of IBS.
How important is the patient's history compared to investigations in IBS diagnosis?
As I mentioned earlier, that history taking is very, very important, because history, the question will lead to the diagnosis of your IBS, because it will exclude your pathological condition. You have to ask the patient when you poop there is bleeding per rectum or not, when your sleep hygiene is how good, how you stress free you are. So these are the various questions. When you talk with patient, then their answer will lead to conclusion in your mind that yeah, this patient is having IBS, not other pathological condition. So it is very, very important. A good history can diagnose a case of IBS.
How do you apply the Rome 4 criteria in day-to-day practice? Can it be simplified for general physicians?
Yeah, it can be applied for general physician. You have to ask in history that your pain abdomen, the duration of your pain abdomen, it is less than 3 months or more than 3 months. Patient is having constipation or diarrhea for 3 months or less than 3 months. So basically the 3 months, if the symptoms are persisting for 3 months and there is on and off diarrhea or constipation and associated with pain abdomen, then we can say that the patient is having IBS. So basically chronic constipation or chronic diarrhea, they will not have any pain abdomen for such a long time. So in a general physician, just ask whether there is pain abdomen or not, or the duration of the symptoms. These will lead to the clue to a diagnosis of IBS. Thank you.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.